Bismillah ar-Rahman ar-Rahim. Welcome. This is Dr. Khaled Diab again. I will continue with you the second part of my recorded lecture titled Abnormal Uterine Action, Uterine Dystocia, and Labor Progress Abnormality. In the first part, we mentioned the 4 new labor progress abnormalities according to Zanning new labor curve. In the second part, we will start discussing each one in details. The latent phase is characterized by regular uterine contractions that soften, efface, and begin to dilate the cervix. The end of the latent phase occurs when the active phase begins. This is usually by 5 to 6 centimeter cervical dilatation. A prolonged latent phase can be defined as more than 20 hours for the nullipara and more than 14 hours for the multipara. It tends to be longer in induced labor compared to spontaneous labor, but the active phase and the second stage have similar duration whether labor is spontaneous or induced. Risk factors for prolonged latent phase is shown in the following slides. Management option for spontaneous laboring women who are not tolerating latent phase include therapeutic rest or the use of uterotonic drugs. Cesarean delivery should not be a primary treatment for laboring women not tolerating latent phase. For women who are tired and uncomfortable in the early latent phase, we suggest therapeutic rest rather than oxytocin. Morphine, 5 to 10 milligram intramuscularly and intravenously simultaneously, not to exceed 20 milligram, give temporary relief by providing analgesia and sedation. Approximately 85% of women treated with this regimen will wake up in the active phase of labor. Oxytocin is appropriate for women who is well rested or has already received therapeutic rest or have another indication to speed labor. ARM alone should be avoided as it is associated with increased cesarean section rates. The diagnosis of protracted active phase is made in women nulliparous or multiparous at cervical dilatation 6 centimeters or more who are dilating less than 1 to 2 centimeters per hour, which reflects the 95 centiles of cervical dilatation. For these women, we administer oxytocin and proceed with amniotomy if there has been adequate fetal descent. If the head is high, we delay amniotomy, administer oxytocin for 4 to 6 hours to allow fetal descent. A controlled amniotomy is performed if the head is still high and not well applied to the cervix. We use a high-dose oxytocin regimen regardless of parity, except in women who have had a previous cesarean delivery. The diagnosis of active phase arrest is made in women more than 6 centimeters or more cervical dilatation with rupture of membranes and either no cervical changes for more than 4 hours despite adequate uterine contraction as calculated by 200 Montevideo units, or no cervical change for more than 6 hours with inadequate uterine contraction. In these cases, we proceed with cesarean delivery. If labor is progressing, either slowly or normally, we continue oxytocin at the dosage required to maintain an adequate uterine contraction pattern. A pragmatic approach is to diagnose a prolonged second stage when a nulliparous woman without epidural anesthesia has pushed for 3 hours, or a multiparous woman without epidural anesthesia has pushed for 2 hours. An additional hour is added for women with epidural anesthesia and sometimes for women with occipito-posterior to allow for long internal rotation, yet with increased risk of operative delivery. We only allow labor to continue if our judgment suggests safe vaginal delivery is achievable. Compared to latent phase, a prolonged second stage has a potential clinical challenge and adverse consequence. Prolonged second stage in multipara multiparous women should be carefully evaluated by a senior obstetrician and should be dealt with case by case, as maternal and fetal and neonatal morbidity and mortality is high. For women in the second stage with minimal less than 1 centimeter or absent descent after 60 to 90 minutes of pushing, and uterine contraction less frequent than every 3 minutes, we begin oxytocin augmentation. Of note, in the second stage, we are more concerned, especially in multipara, about the possible physical issue as malpresentation and malposition or cephalopelvic disproportion as a cause for slow progress rather than the hypocontractile uterine activity. We avoid operative delivery, vacuum, and forceps in the second stage as long as the fetus continue to descend and or rotate to a more favorable position for vaginal delivery as long as the fetal heart rate pattern are reassuring. Prompt operative intervention is indicated for fetus with category 3 fetal heart rate tracing regardless of labor progress. Precipitate labor, also known as rapid labor, is defined as expulsion of the fetus within less than 5 hours of commencement of regular uterine contraction and is typically less than 3 hours. There are several factors that can impact for a rapid labor, including a particularly efficient uterus which contracts with great strength, an extremely compliant birth canal as may be seen in the teenagers, a history of prior rapid labor, birth of a smaller than average baby, a preterm, with hypertensive disorder, especially if associated with placental abruption. Rapid labor can have a number of other potential difficulties for the mother and her baby. The most obvious difficulty with rapid labor is emotional turmoil. Many women feel disappointed as they look forward to the birthing process and are surprised by a rapid labor. A very practical concern of rapid labor is also the location of the birth. Other risk factors for the mother may be increased tearing and laceration of the cervix and vagina with increased postpartum hemorrhage and postpartum shock. Also, delivery in an unsterilized environment such as the car or a bathroom. For the baby, risk of infection from unsterilized delivery, potential aspiration of amniotic fluid. As for management, though you cannot control the speed at which your labor progresses, there are several steps that you can follow in order to take control of the situation in the event of rapid labor. These include call for immediate help, stay in control by using breathing exercise and calming thoughts, have a partner with you at all times, remain in a clean, sterile place until help arrives, lay down either on your back or on your side. Most important is to avoid recurrence. Previous precipitate labor may be an indication for induction of labor in the next delivery. According to Philott in 1982, obstructed labor may be defined as failure of descent of the fetus in the birth canal for mechanical reasons in spite of good uterine contractions. Obstruction often occurs at the pelvic brim, but may occur in the pelvic cavity or pelvic outlet. It occurs among 1 to 3% of all laborers. The following table shows possible maternal and or fetal etiology for obstruction. Also, the following table shows possible maternal and fetal risk associated with neglected obstructed labor. As for clinical presentation of women with obstructed labor, in most cases a prolonged labor precedes obstruction. However, in gram-multiparous women, labor may be quick and relatively silent, and in the presence of mild presentation such as transverse lie, obstructed labor may rapidly occur. Symptoms and signs of maternal exhaustion and stress include dehydration, oliguria, ketosis, symptoms and signs of sepsis. The fetus may show signs of distress and is mostly dead. Abdominal examination revealed the uterus is tonically contracted with formation of what is known as a pathological retraction or banded ring between the upper uterine segment and the lower uterine segment. A possible ruptured uterus may occur with vaginal bleeding. As regards the state of the bladder, usually distended, dilated with hematuria. Vaginal examination reveals ballooned dry vagina, often with full dilated cervix. The cause of obstruction is often diagnosed. Obstructed labor should be an obsolete term in modern obstetrics. In the face-to-face session, we will discuss possible preventive measures, what's known as prophylactic treatment. The standard procedure for obstructed labor is cesarean section when the diagnosis has been made. The choice of operative procedure is dependent on a number of factors, including women's condition, the uterus, whether it's intact or ruptured, the type of rupture, the facilities available, and the experience of the surgeon and the fetal condition, whether living or dead. Surgical options will be discussed in the face-to-face session, which include total or subtotal hysterectomy, laceration repair and tubal ligation, laceration repair alone. Historically destructive operations such as craniotomy, decapitation, evisceration, kiliotomy may be used in jungle obstetrics. The key message in obstructed labor is proper management of normal labor is essential to prevent obstructed labor. Continuous and thorough assessment of the woman and her fetus contribute to limit negative outcome by providing opportunity for timely and appropriate treatment. If obstructed labor is identified, prompt treatment is required to save the life of the woman. It is not always possible to save the life of the fetus. A constriction ring is defined as a persistent localized annular spasm of the circular uterine muscles. It occurs at any part of the uterus, but usually at the junction of the upper and lower uterine segment. It can occur at the first, second, or even in the third stage of labor. Etiology is unknown. The predisposing factors include malpresentation and malposition, pre-labor rupture of membranes, intrauterine manipulation under light anesthesia, premature attempt of instrumental delivery, and improper use of oxytocin as intramuscular use or its use in hypertonic inertia. Cervical dystocia is defined as failure of the cervix to dilate within a reasonable time in spite of good regular uterine contraction. It may be organic, secondary to previous cervical operation or trauma, or functional, primary, due to overactive sympathetic stimulation or due to cervical fibrosis. Clinical diagnosis and complication and management of both conditions will be discussed in the face-to-face session. Also of note, the student is encouraged to read about constriction ring syndrome as pregnancy-related fetal complication. This is my summary slides. Shown in two tables, the student is expected to clearly revise previous information in the presentation. As for this clinical case, the student is advised to prepare it for discussion in the next face-to-face session. Hope this presentation was clear and helpful. The student is advised to read the recommended text and see the YouTube links and be prepared with questions and discussion in the next face-to-face session. Thank you for your time.